Start. ఇది ఫ్యాన్ లేదు ఇక్కడ. ఎంత ఎంత సల్టరీగా ఉంది కదా. వర్షం వస్తుందో మరి, వస్తే మంచిది. Today's class is the mitral valvular disease. There are various valvular diseases that occur due to the rheumatic fever. So next, today is the mitral valvular disease. That is, almost all patients the mitral valve disease is rheumatic in origin and do suffer rheumatic fever. 50% of them may not give history of rheumatic fever. The mitral valve varifies, slowly gets diminished from 5 square centimeter to 1 square centimeter, or much less than that. It is due to progressive fibrosis and inflammation and calcification of the valve leaflets and fusion of the cusps and subvalvular apparatus. So that is the reason and distortion of the annulus of the mitral valve results in narrowing of the mitral valve results in mitral stenosis. The etiology and pathophysiology is once the mitral valve is stenosed, the flow of blood from left atrium to left ventricle is restricted and the left atrial pressure rises and pulmonary venous congestion results, and which leads to breathlessness. So there is dilatation and hypertrophy of the left atrium, and the left ventricular filling becomes more dependent on left atrial contraction. The situation of which increases heart rate or cardiac output, like in pregnancy and during exercise, and exercise is poorly tolerated, and which is shortens the diastole and produces a further rise in left atrial pressure. The atrial fibrillation, progressive dilatation of the left atrium leads to fibrosis of the left atrial musculature, triggers the atrial fibrillation. The pulmonary edema accompanying tachycardia and loss of atrial contraction. And all these lead to marked hemodynamic deterioration. Once there is increase in left atrial pressure, left pulmonary pressure can go up, leads to pulmonary edema. That is the pathophysiology of pulmonary arterial hypertension. The clinical features and the symptoms, the patient usually remains asymptomatic until the stenosis comes down to 2 square centimeters. Patient gets breathlessness due to reduced lung compliance and due to chronic pulmonary venous congestion and pulmonary edema. The fatigue is mostly due to low cardiac output because the left ventricle gets less blood and cardiac output decreases. Because of mitral stenosis, patient develops exercise intolerance. The edema and ascites and right heart failure can result if pulmonary hypertension goes up beyond 50 millimeters of mercury. And they also go for atrial fibrillation. As a result, they develop palpitation. Palpitation can occur in atrial fibrillation and tachycardia. Hemoptysis results due to pulmonary congestion, pulmonary embolism. Cough occurs due to pulmonary congestion. Chest pain is due to eager chest pain, something like heaviness in the chest and discomfort in the chest that occurs due to pulmonary hypertension. And thromboembolic complications do occur in a stroke and ischemic limb. And intermittent claudication due to thromboembolic complication if a patient has atrial fibrillation. The clinical features of suggestive of atrial fibrillation or mitral phases they can have, and that is due to flushing of the face, which can be very well appreciated in fair-skinned individuals with mitral stenosis than auscultation is allowed for snap sound. Opening snap and may be audible and move closer to S2 with increase in severity. Mid-diastolic murmur may be present due to turbulent flow produced in the mitral area because of stenosis. So, which gets accentuated by exercise or any other exercise. Inaudible if the valve is heavily calcified. The murmur may not be audible if the valve is calcified and immobile. The crepitations and due to pulmonary edema and effusions and raised pulmonary capillary pressure will be present due to pulmonary hypertension. So the investigations usually the patient will have the P-or interval which gets delayed, and they may have atrial fibrillation and P-mitral, that is a bifid P wave with prolonged P interval. That is the time for the P wave development is increased, and right ventricular hypertrophy will be presented due to chronic pulmonary hypertension. Will be shown in ECG in the form of tall R wave in V1 to V3 leads, which is and sometimes they may have retrograde P wave, and of course which is rare. The right atrial hypertrophy suggests in the form of a peaked P wave in V1. This is how usually the mitral valve patient with these findings. And right axis deviation and persistent wave in V5, V6 is suggestive of right axis deviation. The chest X-ray shows enlarged left atrium and appendage and signs of pulmonary venous congestion with flooding of pulmonary fluid, that's edema, and curly A lines in the hilar region, which are distended, dilated lymphatics which are present in the hilar region, curly B lines which are present at the costophrenic angles on either side of the thorax, that's costophrenic angles. So usually, and even C lines also may be present in these patients. So other investigations usually, the echocardiography will tell you about the thickened immobile cusp and reduced valve area and reduced rate of diastolic filling of left ventricle and enlarged left atrium. And popular echocardiography definitive evaluation. So that is the pressure gradient of the mitral valve can be judged by Doppler echocardiography, and pulmonary artery pressure can be measured and left ventricular function can be measured in those individuals. Then you have cardiac catheterization that is for the assessment of coexisting conditions. So you can do coronary artery disease by doing a coronary angiography, mitral stenosis and regurgitation, and the pulmonary artery pressure can be measured, and pulmonary venous wedge pressure also can be measured, which will guide for planning the treatment of mitral stenosis. So the pressures usually are recorded by catheterization of the right atrium and puncture the left atrium and go into the pulmonary veins, and initially till you cannot go beyond the resistance, which gives you the pulmonary wedge pressure, which is very important and should not increase usually more than 25 millimeter of mercury. The mitral valve is stenosed and dilated. In mitral stenosis there is dilatation of left atrium and fibrosis of the muscular valve will predispose to develop atrial fibrillation and atrial ectopic sometimes, and they will have increased pulmonary arterial pressure. So if it goes beyond 50 millimeters of mercury, usually they are likely to develop hemoptysis and dyspnea and results in a pulmonary apoplex. They have right ventricular hypertrophy that can be made out, and right ventricular motion abnormality because right ventricle has to work harder to pump the blood into the pulmonary circulation against pressure, against resistance. This is how the echocardiography will help us to manage the patient of atrial patient of mitral stenosis. The management, the patient with the minor symptoms should be treated medically with diuretics to reduce the pre and after load of the heart, and then vasodilators can be tried if necessary. The surgical management, usually patient remains symptomatic despite medical treatment, or if pulmonary hypertension develops much more, the balloon valvuloplasty has to be done, or mitral valvotomy, open heart surgery can be done, and mitral valve replacement can be done. Mitral valvulotomy, you should pass a balloon catheter from the femoral vein, gain entry into the right atrium, from the inferior vena cava, go into the right atrium and puncture the atrial septal defect, and then gain entry into the left atrium and left ventricle through the mitral valve, and inflate the bulb in the left ventricle and pull it out with with little force so that it can break the adhesions of the mitral valve and enlarge the mitral valve diameter. So mitral valve, if it fails, mitral valvotomy can be done by open open the left atrial appendix and put a TURPS dilator and into the mitral valve and dilate it. It will be something like a Cusco speculum in sorry for interruption, which can break the adhesion of the mitral valve. If the valve is very much grossly damaged, and you have to do mitral valve replacement by tilt disc mitral valve prosthetic or job Shelley or Edwards or biophastetic valves, which are manufactured or acquired from pigs and cows, which are of some help, but that disadvantage is which usually degenerates after a few years, 8 or 10 years of time in this patient. But it is patient friendly and hemolysis is much less with this. So medical management constitutes systemic embolism. The patient develops the thromboembolic phenomenon as a result of atrial fibrillation. Usually they have any peripheral vascular disease, mesenteric angina, coronary artery disease, stroke is the commonest which usually occurs. In such a situation, anticoagulants like unfractionated heparin, low molecular heparin and docetaxel can be tried in these individuals till the patient recovers, till you control the patient with atrial fibrillation. Atrial fibrillation can be controlled if it is a definite indication for digoxin or amiodarone or beta blockers. Digoxin is cheap and effective, can be tried in this patient. So digitalize the patient, give 1 milligram of loading dose in atrial fibrillation, then followed by 0.25 milligrams every day for 5 days in a week. 2 days rest can be given, Saturday and Sunday, and whichever the day after the which comes the 5th and 6th and 7th day can be given rest to the patient, which the digoxin will act by delaying the AV conduction, and which decreases the myocardial oxygen demand. Thereby the myocardium acts with greater force with less oxygen supplied to the myocardium. These are the two main actions, but monitor the levels of oxygen so that going to digitoxicity. The result of digitoxicity, they may go into ventricular ectopy, atrial tachycardia, so ventricular fibrillation, and especially people who consume as a lethal dose for poisoning. So that should be kept in mind, and at the same time, electrolytes should be monitored in patient with digoxin therapy. Hypokalemia can precipitate atrial tachycardia and cardiac arrest also. Sometimes hypokalemia may lead to cardiac arrest. The pulmonary congestion diuretic therapy has to be given to these individuals to bring down the pre and after load of the heart, and it also eliminates the fluid from the kidneys, because it increases the cardiac output by increasing the force of contraction of the left ventricle. So the ejection fraction increases, cardiac output increases, urine output also increases in these patients. The pulmonary condition should be treated with diuretics. The furosemide is the best diuretic. In acute pulmonary edema can be given up to 400 milligrams. So 40 to 100 milligrams is usually sufficient. Can go up to 500 milligrams, which usually acts and it's a loop diuretic, which acts on the loop of Henle and eliminates a maximum amount of fluid into the but by diuresis, right? So the antibiotic prophylaxis against the infective endocarditis is no longer routinely recommended in all the patients. Some do accept, Americans do advise, but the Europeans do not advise the prophylaxis. But if you don't, better you give people who live in a low socio-economic groups, overcrowded compartments. So people who live, so many people living in one shed or in hostels, mental asylums, all these situations, the antibiotic prophylaxis is very good, at least in our Indian setup, where we can give benzathine penicillin 1.5 million units once in 3 weeks is of great help in patients with antibiotic mitral stenosis. This surgical management, usually this surgical management is the mitral valvuloplasty. The treatment of choice if specific criteria are fulfilled. Significant symptoms are present to the patient, and if patient has only mitral stenosis and with a trivial mitral regurgitation, and if the valve is mobile, on echocardiography, and if it is non-calcified valve, and subvalvular apparatus is also not calcified on echocardiography, the left atrium is free of thrombus, then we can plan for mitral valvuloplasty in these individuals. So you can, just now I told you, mitral valvuloplasty. This is a balloon mitral valvuloplasty. So you pass the catheter into the right atrium, and from the right atrium to the right ventricle, from inferior vena cava to the right atrium to the left atrium to the left ventricle, and then see, this is after transeptal puncture, the balloon and deflated balloon catheter is advanced across the interatrial septum, and then across the mitral valve and into the left ventricle, and the balloon is inflated stepwise within the mitral orifice, and then pulled back into the left atrium. This is the method by which the balloon valvuloplasty can be done, or balloon valvotomy, mitral balloon valvotomy, and which tears all the adhesions of the mitral valve, and mitral valve gets dilated, and thereby it helps in flow of left atrial blood into the left ventricle, and the pressures in the left atrium and pulmonary venous system, pulmonary arterial system will also come down to near normal depending upon the. Then surgical management is that is valvuloplasty, the closed valvuloplasty, or open mitral valvotomy, or accepted alternative methods of treatment of mitral stenosis. Then you have valve replacement, the substantial mitral reflex if present, or if the valve is rigid and calcified, it has to be replaced by valves, and regular follow-up at 1 to 2 years interval because of restenosis may occur in 1 to 2 years of time in those individuals. So the valve replacement, as we know that the mitral valve has to be replaced, and deceased aortic valve and mitral valve both are present, and mitral valve and regurgitation is also present. So then you can run a 2-disc tilting disc mitral valve or mitral valve prosthesis. One is a discoid, and this is a titanium aortic valve prosthesis that is made up of titanium, or bovine valve can be put here. So then you have mitral regurgitation. So the mitral regurgitation, you find a backflow of blood through defective heart valves can occur during the systole. Usually the blood from the left ventricle will regurgitate into the left atrium. Any one or more of the fine functional components of the mitral valve apparatus are defective, this results like leaflets, defective annulus, chordae, tendinate, capillary muscle dysfunction, and subjacent myocardium, which is scarred, is also one of the important factors. Then you have endocarditis, which damages the mitral valve with vegetations, and which may damage the cusp with abscesses, etc. Papillary muscles may get ruptured due to post myocardial infarction, or maybe due to trauma, road traffic accidents, the steering hitting onto the chest wall. The chronic cases like myxomatous valve prolapse, that mitral valve prolapse due to myxomatous degeneration, or rheumatic fever with the destruction of the mitral valve apparatus, or mitral annular calcification, congenital cleft AV canal, or hypertrophic obstructive cardiomyopathy with systolic or anterior motion, and ischemic left ventricular remodeling, dilated cardiomyopathy with the dilatation of the heart. There will be definite defect in the functioning of the mitral valve, results in mitral regurgitation and radiation. Due to radiation of the heart to treat some tumors, or radiation of the chest to treat bronchogenic carcinoma or secondaries, whatever it is. So accidental damage to the mitral valve apparatus, or any other valve that is radiated will get inflamed and cicatrized and deformed to produce mitral valvular regurgitation. The pathophysiology in regurgitation into left atrium produces left atrial dilatation, but little increase in left atrial pressure if the regurgitation is chronic enough. As the regurgitant flow is accommodated by the large left atrium in a chronic mitral valve regurgitation. And acute mitral regurgitation normally is a compliance of left atrium, does not allow much dilatation, and it also can produce left atrial pressure rises and left atrial side venous, pulmonary venous and pulmonary arterial hypertension also results. The clinical features and the symptoms depend on how suddenly the regurgitation develops. It's a chronic symptom complex that is similar to that of mitral stenosis. In acute, usually presents with acute pulmonary edema and symptoms like dyspnea, orthopnea, pulmonary venous congestion, and usually they have low cardiac output and impaired perfusion of the tissues, and then you have palpitation due to atrial fibrillation, increased stroke volume, edema, ascitic, right heart failure. The signs usually they may have atrial fibrillation, they may develop atrial flutter, they have cardiomegaly, usually displaced hyperdynamic apex beat will be present. So they have pan-systolic murmur, and the thrill may or may not be present. If it is the grade 3, you have a thrill, and pulmonary venous congestion results in a pulmonary edema, crepitations and pulmonary effusion, and pulmonary hypertension and right heart failure can result, and they may go into congestive cardiac failure also. Floppy mitral valve and mid-systolic click also may be present. The prominent third heart sound may be audible over the precordium due to sudden rush of blood back into the dilated left ventricle from the left atrium in early diastolic period. Third heart sound may be present. ECG may show the left atrial hypertrophy that will be seen in the form of P mitral. Left ventricular hypertrophy may be shown because of tall R waves in V5 and V6 chest leads. And chest X-ray is enlarged left atrium and enlarged left ventricle. Pulmonary venous congestion will be present, and crepitations may be audible, and pulmonary edema, if acute, the patient may become sick or seriously ill. Echocardiography shows dilated left atrium and left ventricle and dynamic left ventricle unless myocardial dysfunction predominates, and the structural abnormalities of mitral valve and due to mitral valve prolapse. The Doppler detects, quantifies the regurgitation flow. How much is quantification? Can be done color Doppler study on echocardiography, and then cardiac catheterization. Dilated catheterization cardiac catheterization will show you about dilated left atrium, dilated left ventricle, mitral regurgitation, pulmonary hypertension, and the pressures measurement, and coexisting coronary artery disease. If you can do the coronary angio during catheterization, you can demonstrate, and the patient has significant coronary artery block, you can do a PCI, that is during this at the same setting, you can do PCI in these individuals. So the management is mild mitral regurgitation can be treated medically and diuretics. So vasodilators, diuretics will bring down the pre and after load of the heart, thereby it helps in increasing the after load and decreases the effort on the left ventricle. Digoxin if atrial fibrillation is present, and anticoagulants can be given to these individuals during the phase of atrial fibrillation to avoid left atrial clot formation and thromboembolic phenomenon. And the evidence of the progressive cardiac enlargement in early surgical intervention, valvotomy, valvuloplasty and valve replacement may be of great help to the patient to bring back the enlarged arteries and enlarged left atrium and the left ventricle. If it is an early stage and it better and it regresses back to near normal size of the left atrium and left ventricle and improves the afterload of the left ventricle and pumping ability also improves. Repair the valve and restore mitral valve function by inserting an annuloplasty ring is also important if annulus is very much damaged. To overcome annular dilatation, if it's a very big that can be narrowed and annuloplasty ring can be replaced by artificial annuloplasty ring can be replaced, and bring the valve leaflets closer together so that the valves will function normally. So this is how usually this is about the mitral stenosis and regurgitation. This finishes the cardiovascular system. Exactly 40 minutes.